is 8 a.m. Pacific time, so we will get going. Looks like we've already got 47 people online, which is great to see so much interest for this inaugural webinar. So my name is Ben Adam. I'm a renal pathologist at the University of Alberta in Edmonton, Canada. I'm one of the moderators for today's session. And my colleague Kammi Henriksen from University of Chicago is co-moderating with me. And we are honored to have our esteemed speaker, Dr. Mei Lin Z from Vancouver with us as well. So I'm just going to start off by just giving a brief overview of this series and the motivation behind it, and then some housekeeping items, and then I'll pass it over to Mei Lin. So for those of you that don't know, we're representing the Renal Pathology Society, which is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of renal disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, and encourages training and education in renal disease. And the RPS also sponsors US-based and international conferences and symposia, and brings news and updates pertaining to renal pathology to its members around the world. So today's session represents the first webinar in a new series that the RPS is sponsoring called our Patient Webinar Series. So the primary inspiration for this particular series came from feedback we received during a patient panel at a recent RPS meeting. So the patients and parents of those patients that participated at that particular event expressed a strong interest in consulting with renal pathologists in order to better understand their diagnosis and learn about disease processes. And in fact, there has been a recent push in the larger pathology community to promote patient-pathologist interactions. And there have even been some recent studies showing that there is a high level of patient interest in patient-pathologist consultation programs with motivations including empowerment from viewing the tissue and talking with a pathologist, and interest in demystifying the process of a pathology diagnosis, as well as a desire for enhanced understanding of their diagnosis. So with the intent of further supporting the interaction between pathologists and patients with kidney disease, the RPS launched this patient-centered educational webinar series focusing on the basics of renal pathology and common glomerular diseases, including IgA nephropathy, FSGS, lupus nephritis, and diabetic nephropathy. And through this series, the RPS hopes to empower patients and pathologists alike, and thus work towards minimizing the burden of kidney disease around the world. And I would like to acknowledge that this webinar series is supported by an educational grant from Retrophin, so we thank them for that support. So with that introduction of the series, it is my great pleasure to introduce our speaker for today, Dr. Mei Lin Z, who will be talking on the fundamentals of renal pathology, how to read and understand a renal pathology report. So Dr. Bissonnette is the director of the British Columbia Provincial Renal Pathology Laboratory at St. Paul's Hospital in Vancouver, Canada. She's a clinical associate professor in the Department of Pathology and Laboratory Medicine, and an associate member of the Division of Nephrology at the University of British Columbia. She completed the medical scientist training program at Northwestern University in Chicago, followed by anatomical pathology residency training and medical renal fellowship training at the University of Chicago. So in a moment, I'm going to pass it over to Dr. Bissonnette. So if you have questions throughout the presentation, please enter them into the chat, and then at the end we will read them out for Mei Lin to respond to. And just a note that this session is being recorded and will be posted on the RPS website afterwards. So with that, thank you, Mei Lin, for joining us today, and I will hand it over to you.
Great. Thank you very much, Ben. I'll just share my screen. Okay, well, thank you very much from the Renal Path Society for the opportunity to give this talk today. I'm always excited to talk about renal pathology, especially to anyone who doesn't, really understand what we do or isn't familiar with what we do. And so I'm very excited to give this talk today. And also my Twitter handle is at BC Renal Path if anyone's on that platform, and I'm always happy to interact that way as well. So topics for today, we're going to talk about who pathology and the lab are and what we do. We'll go through what happens after you have a biopsy, how it comes to our lab and what we do, how we look at it and evaluate it, and how we report the results. And we do that with the pathology report, and we'll go through all aspects of the pathology report, including the different sections, the different types of microscope that we use and what we look for, what words we use in the report and what they mean, and how we put it all together to make a diagnosis. And also how we discuss all this information and the report with your kidney doctors to best help with your kidney care. So a lot of people know about the lab from getting blood work done, but we're really this big black hole or a big black box when it comes to knowing exactly who we are and what we do. So you get a biopsy, and afterwards some time passes, then your kidney doctor calls you or sees you in follow-up, and then you get the diagnosis, and then treatment decisions are then based on the results. But you never really physically see who we are and how we're part of your healthcare team. But we see you, at least a small part of you. So these are my colleagues here in Vancouver that I work with. We're all kidney pathologists. And a pathologist is a medical doctor who specializes in the diagnosis and classification of diseases by looking at tissue or cells under a microscope and by interpreting medical laboratory results. So as kidney pathologists, we're specialized pathologists that do this to diagnose kidney disease. And while we've never met face-to-face, we know your names, we know your histories, and we take great pride in making your diagnoses, being part of your healthcare team, and working with your kidney doctors to provide you with the best care possible. And so in the lab, there's the kidney pathologists, but there's also the Kidney Lab Technologists. And so a technologist, and these are some of the few technologists in our lab who were on shift at the time. And the technologist is a laboratory staff member who specializes in the processing of tissue for pathologist review and in the execution of laboratory tests. So the technologists are the ones who do the bulk of the legwork, who process your biopsy, make the slides, and stain the tissue in specific ways so that we, the pathologists, can review them and make your diagnoses and write our reports. And so what happens after you get a biopsy? So the biopsy is usually done in a hospital outpatient setting or in a doctor's office. And there, either your kidney doctor or a radiologist will take a small piece of your kidney tissue and then send it to the lab. So when it's all done, you go home. After a period of time, the kidney doctor either calls you or you go for a follow-up appointment. They give you the diagnosis and then discuss your treatment plan. But what happens during that time between when you have the biopsy tissue taken and when you get the results? Well, that's the time when the lab technologist and your pathologist get to work. So during the biopsy procedure, a kidney technologist will look at the tissue that has been collected and decide how to divide it for the different types of processing and the microscopy that we do to make your kidney diagnoses. And they use a microscope such as this. And this is what they see when they look at your kidney tissue under this special scope. And this is about centimeter and a half in length to kind of give you an idea of scale. And so what our technologists are looking for are these specialized structures called glomeruli. And these are the special structures in your kidney that filter your blood. And what our technologists do under the scope is they make sure that we can see these structures in every different type of microscope that we use. And the different types of microscope that we use are light microscopy, immunofluorescence microscopy, and electron microscopy. And we use these three different types of microscopes together to make your diagnosis. And we describe what we see in these different microscopes in your final biopsy report. And so first, light microscopy. So this is my light microscope that you can see off to my right. And this is what that special filtration structure, the glomerulus, looks like under light microscopy. And this is our lab immunofluorescence microscope. You can see it's a little bit different, also tabletop. And this is the type of things that we could see, and this is what the glomerulus could look like in immunofluorescence microscopy. And then finally, we use the electron microscope, which is a pretty specialized piece of equipment. And you can see that we can see really fine structures in different ways. So you can see that these 3 different microscopes give us 3 very different views of the filtration system and structures in your kidney. So after the kidney tissue has been divided up, either like in-house in our lab or outside, it is then sent to the pathology lab to be processed for viewing under these 3 different types of microscopes. So in British Columbia, all the kidneys for the province come to our institution. We have a centralized location and a provincial program. And so they all come to our lab to be processed and evaluated. And we have a separate kidney space to do all of this, which is shown here. And this is the lab space where all of our specialized equipment is located and our kidney technologists and pathologists work. So that's a general overview of who the lab is and what we do. And so now we'll talk more about the report. So the report is how the pathologists document and communicate the results of what we see under these different types of microscopes. And this is an example of what a kidney biopsy report looks like at our institution. So reports from different places will look different, but each report will document the important details of what was seen in your biopsy, what the results were, and the important information that will affect the management of your diagnosed condition. And so even though the reports may look different, they have all kind of the same general components. And so we'll go through the different parts of a generalized report. So first, the report header. All reports will include a header. And this section includes important identifying information that relates directly to you. So it will include things like your name, your date of birth, hospital or medical record number, all the information that pertains to you as the patient. And so there will also be a specimen or a case number. So this is a number that the lab assigns to your biopsy when we receive it, in order to help us keep track of it when processing the slides, cutting the sections, doing special stains, and for issuing our final diagnostic report. So if there are any questions on a particular biopsy, the case number is the identifier specific to each biopsy that the lab then uses to find this information. So the report will also include the laboratory, contact information for the lab, and also your pathologist who made the diagnosis. And so our lab also documents the tissue that we receive. So our lab, in addition to doing reviewing in-house biopsies, we also receive tissue that was taken at other hospitals and other locations. And so those that are done at outside locations, the tissue is divided and put into special solutions in different containers shown here before it is sent to our lab. So we record the different tissue that we receive in these different containers and solutions, and each of these are specific for a different kind of microscopy. And so we record this because it also helps us keep track of your biopsy, because we receive multiple biopsies each day from very diverse locations. And so what also helps us keep track is the gross description. So when the biopsy tissue arrives at our lab, our technologists look at the tissue and record what they see. And this recording is what's referred to as the gross description. So the gross description is how the tissue looks to the naked eye. So larger specimens that come to the general pathology lab, the gross description will include descriptions of color, consistency, like our certain aspects, firm, soft, etc., and various measurements. So we're dealing with biopsies, which are very small pieces of tissue. So our gross description focuses on the number of pieces that we receive in each container and the size of each piece. And this is done for each of the different types of processing that we do for the different types of microscopy. So all total, this helps us keep track of the many different biopsies we receive each day and keep track of the different tissues for the different types of microscopy. And so then there's the clinical history. And in renal pathology, the clinical history is as important as the tissue that we look at under the microscope. It's how we learn about you. This section includes the information that your kidney doctors give us about your symptoms, lab results, and what conditions or issues they're concerned about and why they wanted you to have the biopsy. So it's how we get to know you as a patient and to know how we can help you as your pathologist. So this information will include things like your age, any medical conditions, like if you have hypertension or diabetes, any symptoms that you may have had recently, like if you had sudden onset of very swollen legs, and any important lab values, like talking about how your kidney is functioning, if there's protein in the urine, if there's blood in your urine, etc. And so the clinical history is how we learn about you and how we know what to look for in the biopsy to provide you with the best possible care. So if we know that there's blood or protein in your urine, but your kidney doctor doesn't know why, we know to look for a cause. But sometimes your kidney doctor knows your diagnosis, but they want to know if your condition is back, if it's worsened, if there are any features that were treatable so that they need to make any adjustments in your management or treatment. And we can answer those questions too. So really the clinical history, this section helps put all of the pathology findings in the correct medical context so that we can provide you with the most appropriate care. And so then comes to the microscopic description. And this is where we talk about the features that we see under light microscopy, immunofluorescence microscopy, and electron microscopy. And this is really the bulk and the meat of the report. This is where we put together all the information that we see in all the different types of microscopes to really make a case for the final diagnosis. And this is where the pathology report for kidney disease is different for other pathology reports, say for those like for cancer resections. And that's because, and this is where kidney pathology gets to be rather confusing, is that there's no one specific finding that defines a particular kidney disease. So when we diagnose things like diabetic nephropathy, there's no one specific finding that helps us reach that diagnosis. It's a culmination of what we see under the different microscopes as well as the clinical history. So we look at all the individual findings from these different microscopes that we look at the clinical information, and use all of this to fit together to make a diagnosis. So for example, diabetes and long-term smoking can cause similar changes within the kidney. And if I'm seeing features that would fit for diabetes, but the clinical history doesn't really talk about the patient's blood sugars, I'll talk to the kidney doctor and see what tests have been done. Does it make sense that the patient has diabetes, or could something else be going on, and do we need to do some more testing? So the microscopic description is where we document all the findings to make the case for the final diagnosis. And so we'll go through all the different parts that are included in the microscopic description with the different types of microscopy. So first, we'll start with light microscopy. So again, this is my light microscope that's here. And it's similar to the ones that you can buy in science kits, but it has a better light and much fancier optics. And it uses a bright LED light to look at tissue that has been processed, cut, and stained on slides like these. So this is an example of part of a set of slides that we would look at for every biopsy. This represents about 1/3 of the total light microscopy slides that we would review for each biopsy. And this is an example of what we would see in a normal kidney in light microscopy. So there are several different parts of the kidney that we always look at in every biopsy. So first is the glomerulus. This is that structure that filters your blood and makes urine. And it's made up of very small blood vessels, and you can see that they are all open here. And there aren't a lot of cells in general when looking overall at the glomerulus. And next are the tubules. So these are the structures that once urine has been made, the urine passes through on the way to your bladder. And also the interstitium. This is the background material that really holds everything together. You can see it's really, it's usually difficult to see under usual circumstances. And then we also look at additional blood vessels outside of what's seen in the glomerulus and all sizes. So here's a small peritubular capillary, part of a slightly larger arteriole, and then larger arteries that aren't shown here. And so when we're looking at all of these different parts, we're looking for basically what's different from normal. And in describing what's different, we use particular words. And so we use these words to describe findings, patterns, and also diagnoses. And kidney reports can be confusing because the words that we use to describe findings and patterns are also the same as the names that we use for specific disorders and diagnoses. And this is because kidney conditions were named for the pattern that was seen on biopsy, but it's resulted in a lot of confusion. And as kidney doctors, we're now trying to help clarify this, where we try to discuss in our reports the underlying cause whenever possible. And so kind of probably the best example of this is focal segmental glomerulosclerosis, or FSGS. And FSGS is, there's going to be a whole webinar in this series on FSGS, but we'll discuss the pattern a little bit. And this is one where there's a lot of confusion because FSGS, the disease, shows an FSGS pattern on biopsy. But not all FSGS patterns on biopsy are due to the same disease. So it can be very confusing, but we'll talk a bit about at least the pattern of FSGS. And so there's words that describe findings, then patterns, and then also diagnoses. So first we'll discuss a few of the words that we use to describe findings. So focal segmental glomerulosclerosis. So sclerosis describes a finding. And sclerosis describes essentially what is a scar. So you can see here is a normal glomerulus, and you can see that there's the blood vessels here are outlined in purple. And basically, sclerosis is a scar where in the glomerulus we see too much purple. And these blood vessels can become closed off with this matrix purple. And because when it's happening in the glomerulus, we describe it as glomerulosclerosis. And it can be found in different patterns, which we'll talk about in a moment. It can be nodular if it's round like a nodule, or segmental if it's only in part of the glomerulus. And so sclerosis is a finding, but then there's also words that describe the pattern of that finding. So there's sclerosis, but what pattern is the sclerosis in? And there's specific words that we use to describe the pattern. So we can use words that describe the number of glomeruli involved. So if we've got 10 glomeruli here, this is focal because it's in less than 50%, or diffuse because it's in more than 50% of the total glomeruli in the biopsy. And we also use words to describe how each glomerulus is involved. So this is total number of glomeruli, but if we just look at one of these, if this involved glomerulus is involved by only, if the affected glomerulus is only involved in less than 50%, that's called segmental. Or if the entire glomerulus is involved or greater than 50%, it's called global. So you take the pattern, focal segmental glomerulosclerosis. It's basically saying that we see a scar that's present in the glomeruli because it's glomerulosclerosis, and it's in less than 50% of the total glomeruli. And in each affected glomerulus, it's in less than 50%. And so here's an example of that. So again, here's a normal glomerulus, and here's a glomerulus involved by FSGS. And you can see here's the area of scar where again that there's too much purple and it's closed off a lot of these small capillaries within the glomerulus. And it's in less than 50% of the glomerulus, and it's only in a few glomeruli. So it's focal segmental glomerulosclerosis. And here's another pattern of glomerulosclerosis. So again, here's normal, and this is a case of diabetic nephropathy. And you can see that the sclerosis, so too much purple here, they look like these little nodules, and it's in the entire glomerulus. So this is a pattern of global nodular sclerosis in the diagnosis of diabetic nephropathy. And so another word that we often use to describe a particular finding is hypercellular, which essentially means there's too many cells, and this can be in the form of inflammatory cells or others. And so in the glomerulus, this is referred to as glomerulonephritis, and we can have hypercellularity in different parts of the glomerulus, whether it's mesangial hypercellularity or endocapillary hypercellularity, just referring to the small locations exactly in each glomerulus, or it can occur in the interstitium, kind of in that background between tubules. And so we'll look at some examples. So for glomerular hypercellularity, again, here's normal. And you can see that these two glomeruli look very different from normal. That just kind of in an overview, you can see that there are too many cells compared to these really open, empty loops here. And so this is a case where there is both mesangial and endocapillary hypercellularity, and it's involving the entire glomerulus. So the pattern is global mesangial and global endocapillary hypercellularity. And that's the pattern. And patterns can be seen in multiple diagnoses. So this is the pattern seen in an instance of IgA nephropathy, where we'll also have another lecture, or lupus nephritis, where there will also be another lecture later in this series. And this is a case where there is, again, too many cells, but now instead of being within the glomerulus, it's within the interstitium. So you can see here normal, that normally there's minimal space in between the tubules, that the interstitium is very difficult to see. But in this case here, where we have a pattern of diffuse interstitial inflammation, so there's interstitial inflammation throughout the entire biopsy, you can see there's large distances between the tubules, and they're being pushed apart by all of these small inflammatory cells here. So the pattern is diffuse interstitial inflammation, and in these instances, the diagnosis was acute interstitial nephritis. And so those are some of the findings and patterns we look for in light microscopy. And as I showed with the IgA and lupus cases, different disorders can have similar patterns on light microscopy. So to help distinguish these different disorders, we also use Immunofluorescence Microscopy, or IF. So IF, and here's the immunofluorescence microscope here. So immunofluorescence uses a special type of high intensity light to make specially prepared slides fluoresce. So this is our IF scope, and you can see it's using a wavelength of light that's blue. And when we put the specially stained slides under it, they will fluoresce green if markers are present. And so you can see that the staining is different, that you can't see it by light, that you need this, by usual light, you need this special light here. And this is about half the number of specially stained IF slides that we review for each biopsy. And so how immunofluorescence microscopy works is that we use antibodies with a particular fluorescent marker. And we use a fluorescent marker that will glow, that will fluoresce green underneath the blue light. And so we use antibodies, and these specific antibodies will stick to specific substances with the kidney. And if the antibody sticks to something, then we'll see the marker fluoresce under the microscope. So in immunofluorescence microscopy, we're looking at which antibody sticks because we use an entire panel and the pattern of how it sticks. And so different conditions will have different patterns of which of the 9 antibodies stick and where they stick and the pattern of how they stick in the kidney. And so here are some examples of how the markers light up in different patterns of how they stick. So again, looking at IgA nephropathy and lupus nephritis. And in IgA nephropathy, this is in particular IgA, and you can see that it's sticking in very discrete locations within the glomerulus, as opposed to lupus nephritis, where it essentially, all the antibodies that we look at stick, and you can see that it's everywhere within the glomerulus. And sometimes it's not just which antibodies stick, but it's also important for which ones don't stick. So this is a case of amyloid, and this is kappa light chain, and this is lambda light chain. And in immune complex diseases like IgA and lupus, we'll see both kappa and lambda stick. But in this case of amyloid, where we only have lambda sticking here, this lets us know that it's a particular type of amyloid, and that's important for not only the kidney doctors, but also for the hematologists or the blood doctors, so that they can do additional workup for this patient. And so we also use electron microscopy. And so you can see it's quite a larger piece of equipment. And what you can't see in this picture is all the auxiliary pumps and the CPU and everything else that goes into this significant piece of equipment. But we use this equipment to look at really small pieces of tissue that are on these metal grids instead of slides. So these metal grids are small enough that we have to handle them with tweezers, and it's difficult to see, but there are about 3 to 4 small pieces of tissue on each of these grids. And instead of using different kinds of visible light, the electron microscope uses a beam of electrons in order to illuminate very small ultrastructures within the kidney. And so we use EM to look at really, really, really small structures. So light and immunofluorescence microscopy, we're usually looking at 20 to 600 times magnification. But with electron microscopy, with the specimens that we're looking at, we routinely look at 600 to 50,000 times. But our electron microscope has a much higher capability that and can go into the hundreds of thousands of magnification. But this is what we'll commonly see underneath in the ultrastructure of the glomerulus. And so we're looking specifically at small, very fine changes that we can't see under light microscopy of things like with the glomerular basement membrane, and also components of the blood-urine filter, such as things like these podocytes here. And we're also looking for any types of deposits that we see within the glomerulus to look at their character and also to better understand where they're located and correlate that with the staining on immunofluorescence microscopy. And so here's an example of the deposits that can be found in lupus. So here's a normal capillary loop seen here. And now this is an involved capillary loop by lupus nephritis. So you can see that there's quite a bit more going on here with these very large, dense deposits here, as well as even these smaller ones here. And this is something that we couldn't really detect by immunofluorescence to this kind of degree of granularity. And electron microscopy also allows us to see difference within the deposits, which also can help with the diagnosis. So again, these are what the deposits look like in lupus nephritis. It's kind of got this very fine, granular, dense appearance. And these are the deposits within amyloid. And you can see that they have this very thin fibril appearance. And we can also look at changes in other parts of the glomerulus. So here's diabetic nephropathy. And you can see in this arrow here it's pointing to that nodular scar, that nodular sclerosis that we've seen before. So you can see that there's an expansion, but without any deposits here. And also in diabetic nephropathy, we see a thickening of the glomerular basement membranes. And so the podocytes are normally they wrap around the small capillaries that are in the glomerulus and contribute to filtration to make urine. And the way that they wrap around, you can see that they have these little projections, which are referred to as foot processes. And so in focal segmental glomerulosclerosis, you can see that there's been loss of these little foot processes, and this is called effacement. And this is a feature when there is a lot of protein in the urine. And so that's kind of the descriptors that we put in the microscopic description. But then that brings us finally to diagnosis. So after we review all the different types of microscopy, we need to put everything together. And in kidney pathology, the final diagnosis is really like a puzzle where we combine the clinical findings, the clinical history, and the lab values with the findings and the patterns that we see on light microscopy, immunofluorescence microscopy, and electron microscopy in order to form a complete picture. And so the diagnosis includes two sections in the report. So the first is the final diagnosis. So this is the section with the main diagnosis and the findings that explain the reason for the biopsy. And this section can also include other important findings that we want to highlight to your kidney doctor that help to either predict long-term kidney health and function. And so here's an example. So again, back to the light microscopic findings for lupus nephritis. And so this is a pattern of diffuse endocapillary proliferative glomerulonephritis. So that's the descriptive diagnosis of the pattern. And in this case, the patient was known to have systemic lupus. So the descriptor is and the pattern is diffuse endocapillary proliferative glomerulonephritis, and the final diagnosis is diffuse active lupus nephritis with the classification system that will be covered in the subsequent lecture. And so in this case, the diagnosis was straightforward. The patient met the clinical criteria for systemic lupus, and the microscopic findings of the three different types of microscopy all fit with lupus nephritis. But sometimes the diagnosis isn't quite as clear. So this was a case where the final diagnosis was actually the descriptive pattern of diffuse endocapillary proliferative glomerulonephritis. And that's because we didn't have enough information to know exactly what this disease, the pattern, could be attributed to. And so we didn't quite have all the pieces of the puzzle to make a more specific diagnosis. And sometimes this happens when we're waiting for lab results. Sometimes when the biopsy is taken, it's taken at the same time that labs are drawn, and not all of those labs have been resulted. Or based on the findings that we see in the different types of light microscopy, additional labs need to be taken to look for additional possible diagnoses. And sometimes patients have very complicated histories, and there's no one clear medical condition, or there might be different medical conditions going on at the same time, so it's difficult to know which process to attribute the kidney findings to. And sometimes, the kidney findings in the three different microscopes don't completely fit together, that there might be a process that it most likely represents, but it's not exactly, it doesn't exactly fit. And so when all of this happens, we use the diagnostic comment. And so the diagnostic comment is for a couple of things. One, when the diagnosis isn't exactly straightforward. And so we use this to explain how the different patterns and findings that we see could indicate different diagnoses. So we'll mention our differential diagnosis, the list of things that it could be, and how these findings do and do not fit together for either one, where we put what we favor. Or sometimes there are important features in the biopsy that the kidney doctors want to know to help them decide on treatment. And as a member of your treatment team, sometimes based on what we see, this is also where we include additional recommendations for the kidney doctor, such as in the case of amyloid, if I can't quite type it, we'll recommend something like mass spectrometry. And so here's an example of a comment explaining important features in the biopsy. So this is one instance where the patient was known to have lupus nephritis and was receiving treatment, but was starting to have symptoms to suggest that the treatment wasn't working quite as well. And so this was one where the diagnosis is lupus nephritis, which is not a surprise to the kidney doctor. But what's important is the amount of activity, because she wasn't really tolerating treatment well. And there was a question of how could her treatment regimen be modified. And so I specifically mentioned how many glomeruli were involved, and the kidney doctor and I had a conversation about how much activity, how much chronicity, what would and would not respond to treatment to try and develop the best treatment option based on how she was tolerating therapy. And so the Kidney Pathology Report is the way that we convey important information to your kidney doctor. But it's not our only way of communicating, because we're part of your healthcare team. And so we'll call your kidney doctor on the phone. And anytime there's any question, or difficulties or questions that we have, that we will discuss these diagnoses, unexpected findings, and work with your kidney doctor to answer questions about treatment. And we'll do this by participating in multidisciplinary rounds as well. And say in British Columbia, we have a glomerular nephritis expert that's located in Vancouver. And if there's any questions that the general kidney doctors will have, the general kidney doctor, the GN specialist, and myself will all have a conversation about the pathology results. And sometimes when this is especially difficult, we will often show the kidney doctor images of your biopsy. And now that telehealth is quite ubiquitous and we have all these resources, showing slides and having these conversations is even easier. And so we've talked a bit about who pathology is and what the lab does, that we're pathologists and physicians that make up, who review your biopsy and make your diagnosis. And there's also the technologists who make this possible by processing, staining, and helping us write the reports. And so we've also talked about what happens to your biopsy and how the tissue that is taken gets divided and processed for 3 different types of microscopy: light microscopy, immunofluorescence microscopy, as well as electron microscopy. And we use all this information to write our pathology reports. And the main sections of the report include the header that has important patient identifying information, as well as laboratory contact information. It includes information about the tissue we receive, including the gross description, which is how the tissue looks to the naked eye and helps us keep track of processing and managing of your tissue within the lab. And importantly, it includes your clinical history. That includes any clinical symptoms, lab test results, or any prior medical conditions. And the bulk of the report is the microscopic description, where the pathologists describe what we see under light microscopy, immunofluorescence microscopy, as well as electron microscopy. And then finally, we have the diagnostic sections, where we put everything together for the final diagnosis, and also the diagnostic comment that provides any additional information or discusses possible diagnoses. And so the kidney pathology report can be a bit confusing because it includes descriptions of findings and patterns under each type of microscopy. And sometimes these patterns and diseases conditions have the same name. And sometimes these different diseases and conditions have similar patterns under the microscope. But as members of your medical team, we always discuss these findings with your kidney doctor in order to provide you with the best care possible. And with that, I'll take any questions.
Thank you so much, Mei Lin. That was amazing. You really put everything like a nice big picture kind of perspective on our daily functioning. So that was extremely helpful. We did have one question a little bit earlier in your presentation. Sam wanted to ask if you could comment on site evaluation of the kidney biopsy while these patients are getting the procedures done either by a radiologist or a nephrologist.
Of course. So on the site evaluation, the technologists are basically looking to see that we have the material that we need in order to make the diagnosis. So it's really a communication between the technologist as well and whoever's taking the biopsy, either the kidney doctor or the radiologist. So they're looking for those little glomeruli, the structures that help filter. So they're looking for that area. And so so that's called cortex. And so how they communicate is that they'll basically let the radiologist or the kidney doctor know, yes, you have enough cortex, and they have enough to put it in the different sections. So we don't divide them equally. Like, we don't need as much tissue for immunofluorescence or electron microscopy, and most of the tissue goes for light microscopy. So it's basically a communication to let whoever's taking the biopsy know that there's enough material.
Another question. Many people thanking you for this wonderful presentation, which is lovely. Do you do EM for all biopsies?
So at our institution, we do EM for all native kidneys. So that's everything that's not transplant. In terms of transplant, we have several different types of biopsies we get. There's a biopsy taken right when the patient receives their new kidney, and that's called implantation 0 hour. And those we do not do electron microscopy for. We only look at those under light microscopy. And for the rest of the transplant biopsies, we don't do electron microscopy if the transplant is younger than 6 months, mostly because if there's going to be recurrence of prior disease or the types of rejection that we would be concerned about within the first 6 months, it's usually not needed. But we take tissue and process it and save it. We just don't cut the grids. So if there's any issue within the first 6 months, we can always do it. We just don't do it automatically.
Here's an interesting one. Do you receive whole kidney specimens? And if so, do you apply the same steps of handling it?
So we do not, mostly because of how our service is set up. So since we're a centralized provincial service, when whole kidneys are taken, for whatever reason, they're done within the pathology labs at the originating institution. So they do not send us any tissue, though if there's any question, they will send it to us in consultation. So at our own institution, the kidney service right now does not review the larger kidney samples, but I'm working to change that. And then we would also, consider taking at the time of the gross description if we need immunofluorescence, EM, etc.
Okay, sorry, I've been neglecting the Q&A. I've been just paying attention to the chat, so I'm going to go back and forth here. Have you ever had a patient call you directly to discuss their biopsy?
So not a patient directly, but I have had patient interactions coordinated with the nephrologist. So where the patient is in the nephrologist's office, they've had questions, and the nephrologist has phoned me and put them on speaker, and we've had a conversation about the biopsy, the three of us together. So I have done that, yes. And it was actually a very good experience. And I think that the patient really felt a lot better about what was going on. So it's something that happens only very rarely, but you know, I think would be great to encourage and have happen more in the future.
Okay, there are a couple people that are asking basically how many glomeruli at site evaluation, how many glomeruli are included in the immunofluorescence and EM, and then someone else asked how many glomeruli are considered sufficient. So those kind of tie together.
So for our lab, the technologist will look to see if we have adequate cortex. So they don't really count glomeruli per se, but if they can see glomeruli within a cortical region, they will take 5 millimeters for immunofluorescence and 5 millimeters for electron microscopy. And in general, we do 5 or 6 blocks of electron microscopy per case, and then everything else will go into go for light microscopy.
And to tie in with that, Sam asked, how would you handle the biopsy with inadequate or limited glomeruli?
So that's always an issue. So this is also where the clinical history is extremely important, because so the technologist will ask us when they have limited tissue how to handle it. And so it really depends what the clinical question is. So say if they're worried about vasculitis or something like that, I'll just put everything into light microscopy, because we have ways that we can do limited immunofluorescence on the light microscopy tissue. We have ways of taking the tissue out and reprocessing it for electron microscopy. So we have a lot of tricks that we can do. But if it's something where they're worried about something that we really have to see the fine ultrastructures on, like sometimes we don't do as much genetic testing in British Columbia. So if there's a question for something like, is the patient an L-port carrier, then we'll make sure that we have sufficient tissue for EM.
Great. One person asked specifically, the number of biopsies taken is, they're asking if you take 7 cores total, 3 for light, 2 for immunofluorescence. I guess it's variable.
Yeah, it's variable because it kind of depends how large the cores are. So with, and you know, different patients can be, it can be easier or more difficult to get the tissue. In general, they take 3 cores, and then based on those 3, they'll take small sections for IF and small sections for EM. And that's kind of a generality. It all really depends on the clinical situation for how easy or difficult it is for in our case, only radiology does biopsies for radiology to take.
A question specifically about your institution. How do you aliquot the material coming from peripheral parts of the province? And what is the experience of your techs when they try to identify the gloms after it sat in Michelle's medium for a while?
So it can be challenging, and we're actually in the middle of a province-wide quality assurance program where we're working with the different pathology departments as well as the different radiology departments, because we're trying to really have a standardized process across the province and have coordinated efforts, because we have intermittent issues with adequacy. So whenever we have tissues from the outside come in, our technologists will re-review the tissue in the 3 different containers, and we'll re-aliquot the tissue as necessary. So sometimes we have like medulla only, which means no glomeruli for light microscopy, but we'll have, you know, a lot of glomeruli, like say 10 for electron microscopy. So we use Karnofsky's fixative rather than straight glutaraldehyde. And so since that's a combination of formalin and glutaraldehyde, we're able to reallocate that tissue back to light microscopy so we can get a better look at morphology. So there's a little bit that we can do, but with Michelle's media, it's a challenge. So we're really kind of, whatever we receive in Michelle's is kind of what we receive. We've tried reprocessing and different tricks, but we've had difficulty.
Okay. Do you use any special stains as a routine?
So for the transplant cases, we do. We'll do an SB40, so looking for BK or JC viremia, nephropathy. We'll do that up front for all transplant cases, but otherwise, we do the standard H&E, PAS, Jones, trichrome. But we have a really low threshold for doing things like Congo red.
Question of, do you use or include references or citations in your reports?
We do, because, you know, one thing about being a provincial service, so we deal with and we work with nephrologists who are at the same types of academic institutions that we're at. We work with with nephrology specialists, so like we have a GN specialist, but we also work with general nephrologists who work in a general community type practice. And so since we see all the different biopsies and we're very up on all the different entities, you know, we do include references, and we'll include those in the discussion with the nephrologists, because we view ourselves, it's not just that we're trying to tell them the diagnosis and what we think is going on, but we also contribute to education as well.
Yeah. Danielle pointed out, she said, this is a wonderful initiative. It'd be great if these lectures and disease series could be openly available to patients and nephrologists, access through the RPS, so our nephrologists can direct patients to consult when they are diagnosed. And yes, Daniel, we will be posting this so that people can access it. I have a feeling a lot of people will be viewing this video in the future. Couple more questions. How are we doing on time? We have a few minutes. If you get medulla only for IF, do you go ahead and process it, or do you cancel the test?
We go ahead and process it because we've had a few instances where, especially because we run the light chains, because we have seen light chain deposition disease or light chain cast nephropathy, that there can always be surprises. I've also seen amyloid in medulla only because we'll get a little bit of fibrous tissue that also has the amyloid. So there's always surprises. So we always process it. But then in those cases, we'll also do the paraffin immunofluorescence for on light microscopy.
Okay, the last question we have at this point, and please send in some more if anyone else has questions. What is your experience with paraffin immunofluorescence, and what do you prefer for antigen retrieval, protease or pronase?
So we use pronase for antigen retrieval, and generally we find it works quite well. So we run the limited panel, so we run IgG, IgA, kappa, lambda. So sometimes we are hindered that C1q and C3 do not work for us, and we haven't managed to sort that out. Sometimes we get a high background in kappa lambda, but otherwise we find it quite helpful. The intensity I find is always dampened compared to frozen. So sometimes we run, for whatever reason, we will actually need to run both. So if we have a 3+ of IgG, you know, it will be a bit dampened in 2+. So there is some modification for how we view intensities.
Right, a little less sensitive. Someone asked, when you were answering the last question, I believe it's when you were talking about, you know, staining the medulla and potentially finding amyloid in the medulla. Someone asked, does it correlate with SPEP?
So sometimes it does and sometimes it doesn't. And that's kind of